Wow.
They have
Assalamualaikum. Okay. Can you just test your audio and then the slides? Otherwise, we're gonna waste sometime the audio and slide, especially the presenters. You try your audio and see the slides.
Hello, can you hear me?
Yes. Yeah.
Hello, can you hear me? Can you hear me?
Yes.
The first presenter, can you just try your slide and see? Then subsequently, other presenter try your slide as well. Okay, all right, okay. This one, okay. Next presenter, can you try your slide and see?
There is only one will present the slide, Doctor.
All right, okay. All right, so is everyone is in already?
Yes, Doctor.
How many are still not in?
Oh, I think
And anyone call them up? All right, okay. Why don't we start?
okay. So Bismillahirrahmanirrahim. My name is Siti Nurhana Atira binti Muhammad Asri. So basically tonight we will have only 3 topics regarding cardiology. So first is valvular heart disease, and then proceed with infective endocarditis, and in the end we will have heart failure in children. So first, without further ado, I will proceed with valvular heart disease. So next. So this is my contents of presentation. Okay, next. So first, I will explain about the anatomy of the heart valve specifically. So technically our heart has 4 valves, 2 on the left and 2 on the right. So all of them basically having 3 cups or leaflets, except for the mitral valve, which have only 2 cups. Okay, so basically physiologically, the blood will return to the heart through the superior or inferior vena cava, and then enter the right atrium, and then we'll go to the right ventricle through the tricuspid valve. So when it is filled or full, it will start to pump the blood to the lung. So the tricuspid valve will close and make a duck sound. So the blood will, the ventricular contraction will pump the blood out through the pulmonary arteries and then go to the lung, and then the oxygenated blood will come back to the left atrium and flow to the um, left ventricle, and the contraction of the left ventricle will close the mitral valve and open the aortic valve and pump the blood out from the heart through the aorta and go to the whole body. So next. So like I've said before, during systole, the mitral valve and tricuspid valve closure will make the loud sound, produce the loud sound of the heart, and in the diastole phase, the pulmonary valve and aortic valve closure will produce the dub sound. So like I've said before, our heart, the valve will have 3 or 2 cups. each. So the name of the cups basically according to the anatomical position of the cups. Okay, for example, for the aorta, we can see there is right semilunar cups of aortic valve, and then we have left semilunar cups of aortic valve, and also posterior semilunar cups of aortic valve. Okay, so can we go back to the previous image? Okay, so basically the tricuspid valve and also the mitral valve, we have the it is connected to the ventricular wall through the capillary muscles via the chordae tendineae, because during the ventricular contraction, it will prevent the valve from prolapse due to the very high pressure. Okay, next. Next. So, what is valvular heart disease? The valvular heart disease basically is characterized by damage or defects in one of the four heart valves. Basically, we have mitral, pulmonary, tricuspid, and also aortic. And aortic stenosis is the most prevalent form of cardiovascular disease after hypertension and coronary artery disease. And basically, rheumatic disease is the most common cause of valve disease worldwide, especially in the young, which estimated prevalence of 15.6 to 19.6 million people. Okay, next. So we have two types or condition of valve dysfunction, which first is stenotic and second is regurgitation. So for stenotic, the valve the valve orifice is restricted and the opening is narrowed due to the calcification occur at the valve leaflets, or there is some fusion if the severity is if it is more severe, and it will affect the forward blood flow. So it will create a pressure gradient across the open valve. Thus, the degree of stenosis reflected in pressure of gradient differences. Okay, if you can see the GIF, during the systole, the narrowed aortic valve will have more pressure is needed to push the blood out from the valve, from the left ventricle. So for the regurgitation, it is the leaky valve, where during the systole, during the left ventricular contraction, the blood will get leaked out from the ventricle to the atrium. So it will have incomplete closure of the valve leaflets that will result in backward blood flow. And usually, valvular disorder occur in children and adolescents, primarily from congenital conditions, and in adults from degenerative heart disease. Okay, next. Okay, valvular heart disease, we can also divide into according to etiologies, which is congenital and acquired. So in congenital, basically we have atresia, which specifically in pulmonary and tricuspid valve. And then we also have bicuspid valve, congenital bicuspid valve. And then we have stenosis, and we also have syndrome associated with valve defects. So for the atresia, it is the dangerous condition because it is a cyanotic heart disease. So we can also have acquired valvular heart disease due to rheumatic disease, connective tissue disease, as well as endocarditis. Okay, so for the syndrome, okay, here are a few syndromes, basically generally for associated with general heart defects. So some of them, such as Turner syndrome, it is associated with bicuspid aortic valve, and also Fajai-X syndrome, it is associated with mitral valve prolapse. So next. Okay, this is another syndrome lah. You can read later. Okay. So what are the common valvular diseases that we can the patient would have? So here the etiologies are basically divided into the specific valve lesion. So as I mentioned earlier in my presentation, the rheumatic disease is the most common one. So if you can see, all of the valve lesion will have rheumatic fever as the cause of the valvular disease. Okay. So next. So before we proceed to the symptoms, I will explain briefly about the pathophysiology. So basically, this is a focus on the left side valve. It either affected indirectly or directly on the left atrial pressure that will eventually causing hemodynamic cascade, which primarily it will reduce left atrial compliance and then increase the pulmonary arterial pressure that will lead to pulmonary hypertension symptoms, and then it either cause remodeling or it will proceed to alveolar capillary pathophysiologic cascade, which also cause remodeling, but the pulmonary alveolar capillary remodeling, which cause gas exchange impairment and will produce symptoms. And in late presentation, the patient might have heart failure symptoms. So let's take a look what the symptoms is. Okay, for the clinical features, for the symptoms, basically in a mild condition, the patient will be asymptomatic except for the cyanotic condition, as I mentioned earlier. And then if the patient is symptomatic, it's basically because of pulmonary hypertension, or the patient is on exertion. The symptom is on exertion. So what symptoms that can the patient have? First is the syncope, and then the patient can also have chest pain due to associated ACS, and then the patient will also having heart failure symptoms such as shortness of breath, autopnea, paroxysmal nocturnal dyspnea, and patient might have palpitation, poor feeding, and extreme sleepiness due to lack of oxygenation. Okay, so what are the clinical features in physical examination? So the signs, we can go step by step. By generally, we can look at the patient, are they cyanotic or cyanotic, because um, it will decide our acute management on the patient. So next, we also need to look at the patient face. Are they pale or flushing? So in pale, the patient might have heart failure due to lack of blood supply or anemia. And then in flush, basically malar flush, the plum red discoloration of high cheeks associated with mitral stenosis due to retention of CO2 and its vasodilatory effects. So next, we can also count the respiratory rate of the patient, and basically in pulmonary hypertension, the patient will be tachypneic. And for peripheral examination, we can feel for the cold extremities, look for the raised JVP, and also any pulse irregularity, narrow, wide, or collapsing. This I will provide later in the last slide, where in a proper table for specific condition. So we can also expect for any sign of heart failure, such as pedal edema. So next we can focus on the pericardium, where we check for any apex beat displacement or any heave or nitrate. And the most important things in valvular defects is murmur. So murmur, I will not explain so detailed, but I will provide a table in the end of my presentation. So for the investigation, so what investigation that we can order? First is chest X-ray to look for any ventricle size changes, dilatation, pulmonary congestion or edema, calcification, and also cardiomegaly. So as for example, in aortic stenosis, we can have prominent left ventricle or stenotic dilatation of ascending aorta, and also valvular calcification in all these types. So next, we can also do ECG from the bedside. So we can look for any atrial enlargement, ventricular hypertrophy, any atrial fibrillation, or any blockage to the heart. So, for example, in aortic stenosis, it is usually normal, but the patient might have left ventricular hypertrophy and inverted T wave if it is long-standing severe stenosis. So next. We can also do echocardiogram. Basically, we have two, which are transthoracic echocardiogram or transesophageal echocardiogram. But the most recommended one is TTE, the transthoracic one, which is diagnostic tool for VHD. Okay, we can look for valvular structure and function. Derangement, and then we can look for ventricular function, ejection fraction, and anatomical info for optimal management. And for expected findings, for example, in aortic stenosis, we can have thickened and doomed aortic valve. Okay, next we can also order cardiac MRI to look for quantitative and accurate volume and function measurement, particularly regurgitation. Okay, so next is cardiac CT for cardiac CT for to look for morphology of valves, basically for classification. So is it fully close the opening, or is only fusion of the leaflets and so on. For others, investigation is basically for the baseline and to rule out any other diagnosis, such as we can order full blood count, coagulation profile, inflammatory markers, blood CNS, and also cardiac enzymes. And it is to look for infection, coagulopathy, coronary artery disease, or any associated acute coronary syndrome. So, as I mentioned earlier, rheumatic heart disease is the most common one. So, what expected finding we can have in rheumatic heart disease is increase in
No.
Okay, for principal management, basically the treatment depends on what valve involved and also the severity of the disease. Okay, so basically we can divide into medication and also surgical. So for the medication, we can give digitally the medication that will reduce the symptoms of the patient and reduce the workload of the heart. Basically, if the patient having atrial fibrillation, you can give antiarrhythmic, and then to reduce the workload of the heart, we can give diuretics, beta blockers, and as we know, if the turbulent flow of the blood in the heart due to stenosis will increase the risk for thrombus formation. So we give anticoagulants, and also we can also give prophylactic antibiotics if we suspected for infective endocarditis. But what I've read, it is no longer recommended. So next is surgical intervention. First is percutaneous transluminal balloon valvuloplasty. So basically, we insert catheter with balloon through any vein of the patient, basically such as femoral vein, to split open fused commissure. Basically, we aim to the defected valve, and then we inflate the balloon to open up the fused commissure. And then, okay, so that's the picture. And then we can also do valve replacement. Basically, we have two types. First is mechanical and tissue. First is mechanical and second is tissue. So for the mechanical valve replacement, we will have to prescribe the patient with lifelong anticoagulant therapy. Okay, so this is the mechanical valve and tissue valve. So basically the indication surgical intervention is based on the severity uh, and the condition of the heart itself, such as if there is congenital heart problems, we will have to do surgical intervention because the patient, such as atresia, the patient might have not survived. So we will have to do surgical intervention. So I think next, okay. So this is the table I've mentioned earlier. It contains the murmur, the sounds, and the clinical sign, such as pulse, that I've not explained so detailed earlier. So you can have, you can take a look later. Okay. So okay. So this is my references. So that's all from me. Any question?
Okay, very good. I think we leave the question at the end.
Okay.
Assalamualaikum warahmatullahi wabarakatuh. My name is Anissa Rashidan and I will present regarding about effective endocarditis. Next. Okay, so what is infective endocarditis? It is an infection on the endothelial surface of the heart, including the heart valve. So this endothelial lesion, we call it as vegetation and usually occur at the valve leaflet. So this vegetation composed of microorganisms that trap in the fibrin mesh. The most common cause in children with congenital heart disease, however, does not undergoes any previous surgery is Viridian streptococci. If let's say the child already undergoes cardiac surgery, the pathogens are Staphylococcus aureus and coagulus negative staphylococci. Next. So about the pathogenesis of infective endocarditis. So initially, it started whenever the patient has valve stenosis or regurgitation. Hence, this will cause the turbulence blood flow. This will promote the endothelial damage and finally cause the body response will cause the platelet and fibrin deposition. Finally, this will lead to non-bacterial thrombotic endocarditis, NBTE, which is sterile thrombus. And then this NBTE will promote the bacterial or fungal infection if the patient has bacteremia or fungemia. So how can someone has bacteremia? It is like by chewing food, toothbrush, flossing, or can happen if the patient undergo any procedure. So whenever there is adherence of the bacteria, it will cause the microcolony formation by the bacteria and lead to the vegetation. This vegetation and up will cause local destructive effect and embolization, focal infection, and host response related complication. So the pathogens that may lead to this infective endocarditis can be divided into bacteria, fungi, and others. For the bacteria, the commonest cause such as Viridian streptococci, Enterococcus, Staphylococcus aureus, and coagulus negative staphylococci. For fungi such as Candida albicans, non-albicans Candida, Aspergillus, and Cryptococcus neoformans, and others such as Coxella burnetii, Chlamydia, and culture negative endocarditis. Next. So this infective endocarditis can be further divided into acute and subacute. If let's say the patient has acute IE, so he or she will present with high sparking fever and usually appear ill. So this acute IE will affect normal valve and the causative agent is Staphylococcus aureus, which can cause rapid destruction of the heart valve tissue, abscess formation, embolic phenomena, and rapidly progressive deterioration in hemodynamic status. Meanwhile, for the subacute, it will affect the damaged heart valve and the patient will present with prolonged low-grade fever with indolent symptoms. So this subacute infective endocarditis usually caused by less virulent pathogens such as Viridian streptococci and coagulus negative staphylococci. Next. So the risk factor for this IE such as congenital heart disease, post-oral dental procedure patient, central venous catheter, surgery or respiratory tract patient, and rheumatic heart disease. However, it is rare. Next. Okay, so the clinical symptom and sign for the IE, for the early symptoms is usually non-specific such as prolonged low-grade fever, fatigue, arthralgia, myalgia, and etc. Meanwhile, for the signs, it usually related to 4 underlying phenomena of bacteremia, valvulitis, immunological response, and embolism. So this patient might present like congestive heart failure, finger clubbing, splenomegaly due to the increased function of the spleen, splinter hemorrhage, and then glomerular nephritis, retinal hemorrhage. Sorry, tak nampak slide tu sampai bawah. Retinal hemorrhage and Osler node. So these are related with immunological, and genuination, which is related to vascular phenomena. So here's the picture of Osler node, genuination, and then the third picture is a picture of splinter hemorrhage, and finally raw spot. Next. So this criteria for diagnosis of IE is based on Duke's criteria. So it has major and minor. For the major criteria, need to be positive echocardiogram with the presentation of vegetation, abscess, or partial descent of a prosthetic valve, or positive 2 blood culture with 12-hour apart. And then for the minor criteria, the patient could be has fever more than 38 degrees Celsius. The patient is IVDU or predisposing to heart condition. The patient has vascular phenomena such as conjunctival hemorrhage or Janeway lesion, and then immunological phenomena such as glomerular nephritis, Osler node, raw spot, or rheumatoid factor. And then either the patient has positive blood culture, however, does not meet the criteria for the major. And then based on modified Duke criteria, this definite IE can be said whenever there is 2 major criteria, or 1 major, 3 minor, or either 5 minor criteria. And for the possible IE, either 1 major, 1 minor, or 3 minor. Next. So the investigation for this IE patient, the first one is full blood count. So it may presented with a low hemoglobin or hematocrit demonstrating the chronic anemia. And then the next one is urinalysis because of the glomerular nephritis. So the patient might presented with hematuria, proteinuria, or red cell cast. And then if we do inflammatory marker, they will be raised high. And then blood culture, which we need to take at least 3 sets from the peripheral vein and not from the central venous catheter. So it need to be taken before the commencement of the antibiotic. Next, we will do echocardiography, both either transthoracic or transesophageal, which the finding include vegetation, abscess, pseudoaneurysm, new dehiscence of prosthetic valve, fistula, or valve leaflet perforation. The next one, we will do cardiac CT, which we can detect intracardiac abscess, pseudoaneurysm, and degree of paravalvular extension. And then the next one, we will do brain MRI to detect any ischemic lesion, microbleeds, and mycotic aneurysm. And finally, nuclear imaging as a supplementary role in difficult case such as prosthetic valve endocarditis. Next. So for the management of this IE, it can be divided into either antimicrobial or surgical intervention. For the antimicrobial, we will use bactericidal instead of bacteriostatic, and then we will give initial high dose parenteral route to achieve the high bactericidal effect, and we will give adequate duration to ensure the complete eradication of this pathogen, which is in between of 4 to 6 weeks. Under the surgical intervention, we will do it on the patient who had heart failure, and then uncontrolled infections such as by the fungi, local extension of infection, or finally, we will do surgical intervention in order to prevent the embolism. If let's say the left-sided vegetation more than 10 millimeter and or very large vegetation more than 30 millimeter. Next. And then for the prognosis, if let's say it is caused by the common organism, so usually it is good prognosis. If let's say it is caused by the gram-negative bacilli, poor prognosis. And if let's say it is by fungal infection, poorest prognosis. That's all from me. Thank you.
All right. Okay. Proceed with the last one.
Assalamualaikum warahmatullah. My name is Hidayatul Alia binti Sobri. Today I will be presenting the heart failure in the childhood. So this is my outline. So first I will talk about the anatomy of heart. So this is the gross anatomy of heart. As you can see, as you all know that heart is an important organ in our body, and it's located in the middle mediastinum in the thorax cavity. And for the heart, it consists of 3 layers, which are the epicardium, myocardium, and also endocardium. So in the heart also, it has 4 chambers, which are the right atrium and left atrium in the upper part, and in the lower part, it has right ventricle and also the left ventricle. So as you can see in the picture, the right atrium, the wall is more dilated compared to the left atrium, and it has more and the space is is more wide than the left atrium. For the right ventricle, also same like the right atrium, the wall is thin compared to the left ventricle. The left ventricle, the wall is 3 times more thickened than the right ventricle. So in between this right atrium and the left atrium, and also between the right ventricle and the left ventricle, they are separated by the interventricular septum, which are uh, consist two part, which is the membranous part and also the muscular part. The membranous part is the thin one, and the muscular part is the thickened one. And as I for the right atrium and the, as I said just now, for the right atrium and the right ventricle, there is a thin wall because uh, the blood, the oxygenated blood in the right side of the heart is low blood, is the pressure is low compared to the right ventricle, whereas right ventricle and right atrium, left ventricle and left atrium and left ventricle, the pressure is high because it has to pump the blood to all the parts of the body. So in the right atrium, it has opening into the superior vena cava and also the inferior vena cava and also coronary sinus. When the blood drain into the right atrium, into the right ventricle, and the right ventricle will open into the left pulmonary artery and also the right pulmonary artery that drains into the left and the right lung. In the left atrium, there is opening from the left pulmonary vein and also right pulmonary vein that receive blood from the lung, and then the oxygenated blood will transfer into the left ventricle and is open into the aorta, and this blood will pump to all the body. And the heart is supplied by the coronary artery, which consists of the right coronary artery and also the left coronary artery. It located in the atrioventricular sulcus and also the interventricular sulcus, and it's formed like crown shape. And also the vein for the heart is from the coronary sinus, and it receives from the great cardiac vein, posterior vein of left ventricles, and also the middle cardiac vein. So this coronary sinus will open into the right atrium. So I will explain about next. I will explain about the normal cardiac blood flow. So in the circulation, there are two, which are systemic circulation and also pulmonary circulation. Systemic circulation is the circulation between the cell bodies and also the heart, and the pulmonary circulation is the circulation between the lung and also the heart. So when uh, uh, when the cell of the body receive the oxygen, and it will release the carbon dioxide. So the carbon dioxide from the lower part of the body and also the upper part of the body and the head will transport into the posterior vena cava for the lower part of the body and also superior vena cava for the upper part of the body. So this deoxygenated blood that contain carbon dioxide will enter into the right atrium, and then will pass through the tricuspid valve, and then it goes to the right ventricles, and then it will go through the pulmonary artery into left and right pulmonary artery, and then it will occur exchange of the carbon dioxide and also oxygen. So the oxygen will exchange from the alveoli into the capillary, and the carbon dioxide will release into the alveoli and will be exhaled, and the oxygen will be transferred to the pulmonary vein and carried to the left atrium and into the left ventricle through the mitral valve, and then it will transfer to the aorta through the aortic valve, and the aorta will transfer the oxygenated blood to the all the part of the body. And the interventricular septums is very important to prevent the mixing of the oxygenated and deoxygenated blood. Next, I will explain I will explain about the left to right versus right to left shunt. So what is left to right shunt? Left to right shunt is the oxygenated blood from the left to the right side of the heart. So the patient usually the
Hold on,
cyanotic.
hold on. I
Okay.
want everyone to picture what do you mean by left to right side. I mean, just again the anatomy of the heart. Okay, the left side of the heart is actually the left side of your hand. Okay, do you have a diagram for this? All right.
Is
Okay.
this?
Then you mean make sure that you know the rest of the when you listen to this, we talk about left to right shunt and right to left shunt. It's actually you're facing the computer. Left is left heart, right? Okay, and right is right. You'll use your hand. So when you listen to the presentation, just again imagine the diagram and with your hand, right and left hand facing the what you call this screen. Okay, all right, you continue.
So the oxygenated blood from the left will go into the right side, which is the deoxygenated compartment, and it is a cyanotic because cyanotics mean there is bluish or purplish discoloration of the skin or mucous membrane because low oxygen saturation in the blood. But in this condition, the oxygenated blood there is no no deoxygenated blood in the systemic circulation because the oxygenated is go to the left to the right side. Okay, for the right to left shunt, this is the deoxygenated blood from the right to the left side. So the patient will present with cyanotics, which is the purplish or bluish discoloration of skin or mucous membrane. So when this deoxygenated, which contain the low oxygen saturation, will go to the left side, which is the left side is the the one that involved to supply the oxygen to the all part of the body. So when this deoxygenated blood with the mixed with the oxygenated blood, there will be low oxygen saturation because there is more carbon dioxide. So the patient will present with cyanotic, and most commonly left to right shunt will present with the heart failure, and right to left shunt also can cause heart failure, and also in the right to left shunt it also can cause embolism because such as in the DVT, the deep vein thrombosis, it will travel from the it can go into the inferior vena cava into the right atrium, and then it can pass to the left. So it can so this emboli can go to the other part of the body and can cause, such as in the brain, can cause stroke. So the example for the left to right shunt are atrial septal defects, ventricular septal defects, and also persistent ductus adhesives. And the example for the right to left shunts are tetralogy of Felix and transposition of the great arteries. So I will explain about the left to right shunt. So this is the pictures of the atrial septal defect, ventricular septal defects, and also patent ductus adhesives. So for the atrial septal defect, as you can see, there is a hole, there is defect between the septum, between the atria. So
Can your pointer can you use your pointer there and show to yeah. Okay.
okay, so this is the oxygenated blood. So when there is a defect in this septum, so the oxygen will come into the right part of the heart. So there will be more blood come into the right compartment, into the right ventricle. So there will be increase in the pulmonary blood flow. So there will be increase more blood into the will enter into the lung. So the lung will be pulmonary congested and can become pulmonary edema. And also same with the ventricular septal defect, there is a oxygenated blood comes from the left side to the right side, and then it will enter enter into the pulmonary blood flow. Same also with the patent ductus arteriosus, ductus arteriosus connecting between the pulmonary artery and also the arch of aorta. Usually right after the birth, this ductus arteriosus will uh, will there is no more patent, there is no ductus arteriosus. So when there is ductus arteriosus, there the blood which is high pressure from the from the aorta will shunt to the right part. So this shunt occur because as we know that the right ventricle, the blood is more more high pressure compared to the left ventricle. The blood is high in pressure compared to the right part. So they will be occur left to the right shunt. So in the chest X-ray, we can see the features of the heart failure, such as enlarged heart. Enlarged heart occur because when there is more blood in the pulmonary blood flow, so there will be increase in the pulmonary resistance. So the right ventricle will be, when there is pulmonary resistance, high in pulmonary resistance, the right ventricle will become hypertrophy. And also when there is increase in pulmonary blood flow, then the blood from the lung will go back to the heart, which is the venous return will also become high. So when the venous return high, and also there is more blood, will enter the left atrium and the left ventricle. So the left atrium and the left ventricle also will become dilated. At the end, it will become the hypertrophy. So we can see the clinical features of the enlarged heart, and also enlarged pulmonary arteries, because there is more pulmonary blood flow, so there will be pulmonary edema, so they will increase in enlarged pulmonary arteries and increase pulmonary vascular markings.
Okay,
So
and
this is,
in again, you show again the picture, previous slide. Okay, in left to right shunt, the diagram just now. Yeah. Okay, and the left to right shunt, there's no cyanosis, right?
yes,
Yes. Can you explain why? Because the blood already been oxygenated in the lung. Okay.
yes,
All right. So that's a different. Usually left to right. Usually rarely you have cyanosis. I remember because the blood already been oxygenated in the blood, and then the shunting occurs after that. Okay. Hopefully the rest of you have got clear about this. Okay. Continue.
okay. So this is the diagram to understand more. The shunt depends on the compliance, right versus left ventricle, blood viscosity, size of the defect, the gradient between the chambers, and the ratio between the pulmonary vascular resistance and the systemic vascular resistance. So when there is arterial or ventricular shunt, they will increase in the right ventricular filling, that will increase at the end the endostolic volume, and also the endostolic pressure in the right side of the heart. So the right side will become hypertrophy and also become right ventricular failure. So, and also increase in pulmonary blood flow will cause the pulmonary edema. Pulmonary edema will cause the increase in the pulmonary vascular resistance that lead to right ventricular failure, and increase in pulmonary vascular resistance cause the pulmonary hypertension that at the end cause the right ventricular hypertrophy. When there is right ventricular hypertrophy for long times, the pressure in the right ventricular will become more than the left ventricular. So it will reverse from the right to the left. So we call this as Menger syndrome. And also ventricular, as when there is increase, this left to right shunt also can cause increase in the left atrial and left ventricular blood flow, that cause increase in left ventricular endostolic volume increase and left ventricular endostolic pressure increase, that lead to the left ventricular failure. And also this condition can lead to the pulmonary venous congestion. So next, I will explain right to left shunt. So right to left shunt, there are two examples which are tetralogy of Fallets. This is tetralogy consists of 4 characteristics, which are the overriding of aorta, pulmonary artery stenosis, and also ventricular septal defect. Usually the tetralogy of Fallot have large ventricular septal of defect. So and with this condition, when there is pulmonary stenosis, this will cause increase in the resistance. So when there is increased resistance, the right ventricle try to adapt with this condition, and at the end the right ventricular become hypertrophy. So this will shun the blood from the right to the left. So you see this is the blue one, which is the deoxygenated blood will shun to the left compartment of the heart. So as we all know that left compartment of the heart will supply the oxygen. So this deoxygenated blood will supply to the part of the body, and the patient becomes cyanosis because this blood contain less oxygen saturation. And also this is the finding in the X-ray, which is small heart uptical effects, and also the pulmonary artery bay, and also oligamic lung fields. Next is transposition of great arteries. And transposition, as we all know that right ventricle is open into the pulmonary artery, and left ventricle is open into the aorta. So in this condition, the aorta is connect to the right ventricle. As we all know that right ventricle receive blood from the body cells, from the body. So which is the deoxygenated blood, and aorta supply the blood to the body. So the right ventricle only receive blood from the body and then send back to the body part, which is there is no mixing between the oxygen and deoxygenated. And same with the left ventricle, it receive the blood from the lung and send back the blood to the lung. And usually this patient is incompatible with life unless there is septal defects such as ventricular septal defect or atrial septal defects that allow the mixing of the heart. And the patient will survive more, survive bit compared to the patient that have only transposition of right artery. And uh, at the end, the patient will present with the heart failure. So this is the features of uh, the chest X-ray for the transposition of grade 3, which is narrow pedicle, egg on site cardiac puncture. This is the egg shape, and then increased pulmonary vascular markings. Next, I will explain about the causes of heart failure. As we all know that heart failure is the inability of heart to provide adequate cardiac output to meet the metabolic demands of the body. So the causes of heart failure, according to the PITS protocol, it divides into the congenital heart disease, acquired valvular disease, and myocardial disease. Usually the congenital is more common during infancy, and primary myocardial and also acquired valvular disease is more likely in older children. The example of congenital heart disease that's common is left to right shunt, PSD, PDA, FASD and ASD, and also obstructive left heart lesion, which are hypoplastic left heart syndrome, contraction of aorta, common mixing unrestricted pulmonary flow, valvular regurgitation, myocardial ischemia, and acquired such as chronic rheumatic valvular disease post-IE, and myocardial disease such as primary cardiomyopathy, secondary cardiomyopathy, infections such as viral myocarditis, Kawasaki, muscular dystrophy, Pompe disease, hypothyroidism, atracycline drug of cancer chemotherapy, iron overload, and also viral causes such as viral myocarditis and also Kawasaki. And next, we also can divide the heart failure by the age group, which are the fetus, premature neonate, full-term neonate, infant or toddler, and also child or adolescent. So in fetus, usually this is the causes, which is severe anemia, ventricular tachycardia, complete heart block, and so on. And then premature neonate, usually due to congenital such as PDA, VSD, or pulmonary. And full-term neonate, usually it presents with the left-sided obstructive lesion, such as coarctation of aorta, hypoplastic, left heart, critical aortic stenosis, and other examples such as asphyxial cardiomyopathy, AV malformation, TGA, viral myocarditis, anemia, supraventricular tachycardia. And infant and toddler usually present with usually the causes is left to right cardiac shunt, VSD, and other causes such as hemangioma, anomalous left coronary artery, metabolic cardiomyopathy, acute hypertension, and Kawasaki disease, and others. And also child or adolescent, usually due to rheumatic fever, acute hypertension, viral myocarditis, thyrotoxicosis, laser therapy, and others such as coronary upper airway obstruction. You can read after this. And then the clinical manifestation, what we can see in the patient with heart failure. In infants, they present, and young children, they present with difficulty in feeding, such as interrupted feeding and prolonged feeding times. And tachypnea, to compensate their heart failure. Diaphoresis due to sympathetic nervous system activation, pallor. And for the children and adolescents, they will present with shortness of breath, dyspnea, decreased effort tolerance, decreased effort tolerance, abdominal pain, nausea, and vomiting. And rarely in child, we can see ankle edema, ascites, facial edema, chest pain, and palpitation like in the adult. And also other symptoms such as recurrent chest infection and also orthopnea. So this is the picture for the presentation of right heart failure and also left heart failure. For the right heart failure, it is more on systemic congestion. The patient present with the raised JVP, hepatomegaly, ascites, peripheral pitting edema, but it is rare to see raised JVP and peripheral pitting edema and ascites in the children. And also in the left heart failure, the patient present with cardiomegaly, pleural effusion, pulmonary edema, the common one. And in the sign, we can see the child have poor weight gain or the slow growth, and also the patient also present with tachycardia, poor peripheral pulse, poor peripheral perfusion, and cool peripheries. In cardiac findings, we can hear heart murmur or gallop rhythm, heart murmur in the VSD, ASD causes. And also in infant, we can see is there any hyperactive precordium or precordial bulge. In the pulmonary finding, we can see any resting tachypnea, wheezing because of pulmonary edema and subcostal recession. We can see in infant, which is one sign of the respiratory distress and systemic finding that I said just now. So we go to the investigation. So there are three diagnostic investigation, which are chest X-ray, ECG, and echocardiogram. Chest X-ray is usually the first line of investigation. We want to see the size of the heart. Is the heart is small, normal, or large, and the contrast of the heart, the pulmonary vascularity, either it is increased, decreased, and the signs of fluid overload, such as cardiomegaly, Furley lines, and pulmonary edema. And also ECG, we want it is always normal in children with heart failure, and it's generally non-specific. And the example for heart failure finding ECG is sinus tachycardia and left ventricular hypertrophy. And echocardiogram, we want to look any structural cardiac defects such as ASD, VSD, and also chamber size. It is small, either it is dilated or not. And also we want to assess the cardiac function. Next, other investigation that we can do is full blood count to look for anemia that can cause or aggravate the heart failure, electrolyte to look the patient have low potassium chloride due to prolonged use of diuretic, renal profile to look any renal impairment due to treatment of heart failure, liver function test because we want to look raised liver enzyme due to liver congestion, natriuretic peptide. We want to distinguish heart failure from respiratory or other non-cardiac disease. Lactate, usually we want useful in patient with acute decompensated heart failure to guide our management. And then ABG, to look hypoxia or metabolic acidosis, thyroid function test to exclude thyrotoxicosis, cardiac troponin, which is increased troponin T in acute myocarditis and increased troponin I in dilated cardiomyopathy. And then metabolic genetics testing in children with unexplained cardiomyopathy, and viral study for the patient that suspected acute myocarditis, endomyocardial biopsy in patient suspected myocarditis but the yield is low, and cardio CT scan or MRI, and it is useful for diagnosis of primary cardiomyopathy, myocarditis, complex congestive heart disease, congenital heart disease, or rare extracardiac malformation. And the last one is cardiac catheterization. It's indicated for complex congenital heart disease, congestive heart disease. And next, I will explain about the classes of the anti-failure drugs. So heart failure cause reduce in the cardiac output. When there is reduce in cardiac output, it will cause the sympathetic nervous system activation that will release the renin angiotensinogen, renin that convert that cause the to produce angiotensin 1, and angiotensin 1 will convert to angiotensin 2, and angiotensin 2 will produce aldosterone, and this aldosterone will cause the cardiac remodeling, which is the ventricular hypertrophy, and also angiotensin 2 also cause cardiac remodeling. So this aldosterone also cause Na, sodium and water retention, that so the patient will present with the edema, peripheral edema, and cause elevated cardiac filling pressure. So this all of this can deteriorate the heart failure more. So what medication we give? Diuretics, which furosemide and spironolactone. Furosemide act on kidney, so it will cause the salt excretion at the ascending loop of Henle. So when there is salt excretion, so the extra cellular fluid and venous pressure will be reduced. So will be reduced preload into the heart. So we can reduce the cardiac workload and oxygen demand by the heart. So this is the adverse effect for the furosemide, such as anaphylaxis, anemia, anorexia, and you can read after this. And then spironolactone, usually we give with the furosemide. It is the aldosterone. It competitively inhibit aldosterone receptor, and it promotes sodium and water excretion and potassium retention. Spironolactone is the potassium sparing diuretic. We give this with furosemide, and spironolactone also useful to prevent um, cardiac remodeling, because we'll know, as I explained just now, aldosterone cause cardiac remodeling. So spironolactone is beneficial to prevent cardiac remodeling. So the adverse effects such as irregular menses, gynecomastia, headache, and the other symptom, the other adverse effect. And then ACI, angiotensin converting enzyme, which are the captopril and enalapril. So this drug will inhibit the angiotensin converting enzyme, so they will be reduced in the angiotensin 2 production. As we all know, angiotensin 2 production will cause the edema, will cause the cardiac remodeling, and also it will cause the vasoconstriction. So we want to prevent this by giving them captopril and enalapril. Captopril usually give during the infant, and enalapril give in the children more than 2 years old. So this is the adverse effect for captopril, such as hyperkalemia, kidney impairment, skin rash, and others. And enalapril adverse effects such as dizziness, hypotension, headache, chest pain, dry cough, and rash. Next is the beta blocker. Beta blockers such as propanolol, metoprolol, and carvedilol. So when this beta blocker bind to the beta adrenal receptor, they will block the binding of the norepinephrine and epinephrine to this receptor. So we will inhibit the normal sympathetic effects that act through this receptor. So these are the adverse effect for the propanolol, which are dizziness, lightheadedness or tiredness, and others. And also metoprolol also same, dizziness, headache, tiredness, cold extremity, constipation, and also same in the carvedilol, hyperglycemia, diarrhea, bradycardia, and others. So, and the last, which is the inotropes. Inotropes is the drug that increase the contractility of heart. It causes the influx of the calcium into the muscle, into the heart muscle. So it will increase the cardiac contractility. So the example such as dopamine, which is the under the group of beta receptor agonist, where it bind to beta receptor, and also dobutamine, same action like dopamine. And usually the dobutamine is combined with the dopamine, and the adverse effect, ventricular arrhythmia, atrial fibrillation, and also in the dobutamine also tachyarrhythmia, hypertension, premature ventricular beats. And next is milrinone. Milrinone is the phosphodiesterase 3 inhibitor with positive inotropic properties. It decreases vascular resistance or afterloads, and it also causes ventricular arrhythmia, supraventricular arrhythmia. So this is the mechanism of action. Dopamine or dobutamine, it will bind to the beta adrenergic receptor. So the ATP will convert to CAMP. CAMP will activate the protein kinase. So there will be phosphorylation of calcium into the cells. They will increase the force of contraction. And this is the milirenon action. It will prevent the CAMP convert to AMP. So it will prolong the action of the protein kinase. So the last one is the digoxin. Digoxin is it inhibits the membrane Na plus K plus ATPase and increase the intracellular calcium also and improve cardiac contractility. Digoxin is has narrow therapeutic index and it is very toxic. It has high toxicity and need to be monitored. So it is rarely used in the children. And the adverse effect is dizziness, mental disturbance, and others that I have stated here. So I think this is my reference. This is I think that's all from me.
Okay, all right, very good, everyone. Okay, any question in relation to this presentation? I think a summary is actually that's why we start with no anatomy of the heart. I think you have to understand the anatomy and then the cardiac flow, the structure, then it actually makes sense, right? And it makes sense that what is right and left heart failure. It makes sense why some condition are cyanotic, some condition is cyanotic, and you will then it makes sense also which anti-failure that we need to start, right? So in a way, cardiology is a quite straightforward if we understand the anatomy. So for long case, I think quite common to have this condition. Not specifically valvular. Usually in your long case would be mix of congenital heart disease like Down syndrome. Right, and then the cyanotic heart disease usually, if come for exam, is most likely is the non-complex for your level third year. Usually one or two lesion, Down syndrome with some heart condition. Complex heart disease rarely will come out even in your final exam, but it's good to know to understand the concept. All right, any question? You understand? I think again, you sit down and look back into the right and left shunt, but you have to start with the anatomy. Then it definitely makes sense. Why when the chest X-ray also no polygemic means that there's no congestion, just black. I think it makes sense. So anyone has any question? I think quite good. I mean, you just look back into the slides that that they've been prepared. I think these are quite good. Is a good summary as well. Again, look back into the anatomy. Okay. Okay, everyone, quite clear?
Yes, doctor.
Okay, no question.
Yes, doctor.
Ada question? Tak ada I think everyone has presented quite well. I think quite clear, straightforward this one. Very good. Okay. Right, if tak ada question, then we end up with the speaker Farah. So ask. Okay, Assalamualaikum warahmatullahi
Thank you, doctor.
Thank you, doctor.
Thank you, doctor.
Doctor.